Anchoring. The common human tendency to rely too heavily on the first piece of information offered, the anchor, when making decisions. Diagnostic momentum. Once a diagnostic label has been attached to a patient by the patient or other healthcare professionals, it can gather momentum with each review, leading others to exclude other possibilities in their thinking. Premature closure. The tendency to close the decision making process prematurely and accept a diagnosis before it and other possibilities have been fully explored. Ascertainment bias, when sometimes we see what we expect to see, self fulfilling prophecy. For example, a frequent self harmer attends the emergency department with drowsiness. Everyone assumes he has taken another overdose and misses a brain injury. Framing effect, how a case is presented, for example, in handover, can generate bias in the listener. This can be mitigated by always having healthy skepticism about other people's diagnosis. Psych out error. Psychiatric patients who present with medical problems are under assessed and under examined and under investigated because problems are presumed to be due to or exacerbated by their psychiatric condition. Availability bias. Things may be at the forefront of your mind because you have seen several cases recently or have been studying that condition in particular. For example, when one of the authors worked in an epilepsy clinic, all blackouts were possible seizures. Hindsight bias. Knowing the outcome may profoundly influence the perception of past events and decision making, preventing a realistic appraisal of what actually occurred, a major problem in learning from diagnostic error. Search satisficing. We may stop searching because we have found something that fits or is convenient instead of systematically looking for the best alternative, which involves more effort. Base rate neglect, the tendency to ignore the prevalence of a disease, which then distorts Bayesian reasoning. In some cases, clinicians do this deliberately in order to rule out an unlikely but worst case scenario. Omission bias, the tendency towards inaction rooted in the principle of first do no harm. Events that occur through natural progression of disease are more acceptable than those that may be attributed directly to the action of the healthcare team. Triage queuing. Triage ensures patients are sent to the right department. However, this leads to geography is destiny. For example, a diabetic ketoacidosis patient with abdominal pain and vomiting is sent to surgery. The wrong location, surgical ward, stops people thinking about medical causes of abdominal pain and vomiting. Commission bias, the tendency towards action rather than inaction on the assumption of that good can come only from doing something rather than watching and waiting. Overconfidence bias, the tendency to believe we know more than we actually do, placing too much faith in opinion instead of gathered evidence. Unpacking principle, failure to unpack all the available information may mean things are missed. For example, if a thorough history is not obtained from either the patient or carers, a common problem in geriatric medicine. Diagnostic possibilities may be discounted. Confirmation bias, the tendency to look for confirming evidence to support a theory rather than looking for disconfirming evidence to refute it, even if the latter is clearly present. Confirmation bias is common when a patient has been seen first by another doctor. Posterior probability, our estimate of the likelihood of disease may be unduly influenced by what has gone on before for a particular patient. For example, a patient who has been extensively investigated for headaches presents with a severe headache and serious causes are discounted. Visceral bias, the influence of either negative or positive feelings towards patients which can affect our decision making. Figure 1.7, common cognitive biases in medicine. An understanding of these interactions makes it easier for healthcare professionals who are committed to first do not harm to work in the safest way possible. For example, performance is adversely affected by factors such as poorly designed processes and equipment, fatigue, and poor communications. So, simple, clear processes, good design of equipment, and shift patterns, and clear team communication all help to minimize errors. The areas of the brain required for type 2 processing are most affected by things like fatigue and cognitive overload, and the brain reverts to type 1 processing to conserve cognitive energy. Figure 1.8 illustrates some of the internal and external factors that affect human judgment and decision making, and awareness of the factors that impact on decision making can allow clinicians to take steps to mitigate this.